Now we will turn our attention to electrical conduction from the atria to the ventricles. In the normal heart, the atria are electrically insulated from the ventricles by the cardiac skeleton, which includes the tricuspid and mitral valves. The only natural electrical connection between the atria and the ventricles is the atrioventricular node, or AV node. Sometimes this connection becomes compromised, and then you get AV block. Other times you have an extra muscular electrical connection between the atria and the ventricles, and we went over this earlier and it's called an accessory pathway. So in this section we'll talk about common electrical issues in and around the AV node and the AV valves. Here's an outline of this section. First we'll go over AV block. We will discuss first degree, second degree, and third degree AV block. Next we will review junctional rhythms. And remember, junctional rhythms happen just below the AV node. Finally, we'll go over an example of pre-excitation, the electrical signature of an accessory pathway. Okay, let's start with the basics. First degree AV block. So first degree AV block is really common in patients with structural heart disease. In first degree AV block, every atrial P wave is still conducted to the ventricles, and so there is a one-to-one relationship between the P and the QRS. However, it takes a lot longer from a signal to go from the atria to the ventricles in first degree AV block. The official definition of first degree AV block is a PR interval longer than 200 milliseconds, which equals about one large box. Usually this condition doesn't cause many symptoms, and under most circumstances, we usually don't put a pacemaker based on this electrical finding. So here are some windows showing the length of the PR interval, and that's greater than one large box, and so this is first degree AV block. As you can see here, the PR interval is greater than 200 milliseconds. Here's a more extreme example of first degree AV block, and in the yellow boxes you can see that the PR interval is at least 300 milliseconds, or greater than 1.5 large boxes from the QRS. Notice too how the T wave of the preceding heartbeat starts to bury the next P wave, and the waves start becoming indistinct because they start to merge together. This is an example of a more diseased atrium and diseased AV node, but it hasn't yet progressed to dropping QRS waves. So next is second degree AV block. So before I explain this, I want to say that the terminology here is a little bit clumsy, and I find that it can be confusing to many students who are learning ECGs for the first time. So second degree block just means that the patient is starting to have enough AV block that they're starting to intermittently drop QRS waves. They're starting to intermittently drop QRS waves. And within second degree AV block, there are two primary types. Mobitz 1, which is more benign, and Mobitz 2, which is more severe. This ECG is an example of Mobitz 1 type block. On a general survey of the ECG here, you can see that there are some unexpectedly dropped QRS waves that occur on the left and to the right of the ECG. If we look a little bit closer, we will find that the PR interval actually gets progressively longer until you see a P wave with a dropped QRS. And then immediately after the blocked QRS, the PR interval tightens up again, it's shorter, before progressively getting longer and longer, and then dropping another QRS. Usually Mobitz 1, second degree AV block, causes few symptoms and is usually not a reason to place a pacemaker unless symptoms are really severe. Let's contrast this now with Mobitz 2. This is a more severe type of second degree AV block. Notice here that before and after a dropped QRS beat, the PR interval is essentially the same. This is a huge problem because it means that the electrical problem is below the AV node and in the His-Purkinje system, and this is not really reversible. Usually this is an example of high-grade AV block and sometimes can be a cause to place a pacemaker. So again, to be clear on terminology, we call this second degree AV block because there are intermittently dropped QRS beats. And we call this Mobitz 2 second degree AV block because of the fixed PR interval leading up to and then after the block. and which signifies more severe block that may need a pacemaker. Here's a situation that's really difficult to interpret, even for seasoned cardiologists. In this ECG, we see 2 P waves for every QRS. Essentially, we have a P QRS, and then we have a P wave and a dropped QRS. And this happens over and over. And we can't really tell if the PR interval is prolonging because there's only one PR before and one after for comparison, and they're both equal. And we can't really say that the PR is fixed because we only have an N of 1 on this one. So this special category is called 2-to-1 AV block. And we will essentially need a tiebreaker to push the physiology a bit, either in the Mobitz 1 or Mobitz 2 direction. One way to do this is to challenge the patient with exercise on a treadmill. Because Mobitz 1 happens higher up in the AV node, and the AV node is innervated by the autonomic nervous system, exercise will usually stimulate the sympathetic nervous system and improve AV conduction. Conversely, because Mobitz 2 occurs in the His-Purkinje system, and which doesn't really pick up a lot of sympathetic stimulation, conduction will actually worsen at higher heart rates. By challenging the electrical conduction system with a stressor, the true identity of second-degree AV block can then be determined. Sometimes AV conduction deteriorates so badly that there's essentially no conduction from the atria to the ventricles. This is called third-degree or complete AV block. Because the intrinsic rate of the atria is usually higher than the ventricles, usually you see more P waves than QRS waves here. In this example, you can see that there's essentially no relationship between the P wave and the QRS waves. Each P wave seems to be independent from the next QRS, and sometimes it looks like the P waves are just sliding past the QRSs without any coupling at all. Typical symptoms for a patient with third-degree AV block include dizziness, lightheadedness, and passing out. Complete AV block is an indication for a pacemaker, and a patient doesn't even need symptoms in order to qualify for the pacemaker. We saw an example of junctional tachycardia in the previous atrial pathology section, but I wanted to bring up here that the junction does not necessarily have to be tachycardic in order to have a junctional rhythm. Here we see an example of sinus bradycardia and with a junctional escape rhythm. Essentially, the sinus node is going so slowly that sometimes the area of muscle surrounding the His-Purkinje system becomes autonomous, and this muscle fires, leaving a QRS wave without any discernible P wave. In this example, you can see first a conducted P wave, like the first beat, especially in lead V1. And then, long after the sinus pauses, you can see a QRS without a P wave, like on the fourth QRS. This is an example of junctional escape during sinus bradycardia. Here's another example of a junctional rhythm that's firing at about a rate of 60 beats per minute. In this ECG, we really don't see any P wave here, so we know the patient is not in sinus rhythm. But unlike atrial fibrillation, we see that the QRS waves are extremely regular. So this is an example of a junctional escape rhythm where an area near the AV junction has essentially electrically woken up and taken control of the electrical rhythm of the heart. And as we saw before, the junction can fire rapidly, and we call this junctional tachycardia. And as we saw in the previous atrial pathology section, this is a type of supraventricular tachycardia. I wanted to spend a minute on ventricular preexcitation, because this is a common ECG that you'll see on your pediatrics rotation and also on several shelf exams, including pediatrics, internal medicine, and family medicine. At first glance, this ECG may not seem to appear unusual. You have a P wave followed by a QRS, and we notice by a negative QRS in lead AV foot that there is some left axis deviation. But if we look closer, we see that in several leads, like lead 1 and 2 and 3, the P wave is actually fused to the QRS. And there's a curved upslope shape to the QRS that looks like a mountain or like a ramp. Look at the upslope in lead V4. This is definitely not the normal sharp shape of the QRS. Many patients with this ECG pattern will have an accessory pathway, but they may never have had any symptoms. You will often see patients who happen to get a sports physical and an ECG, and then they may come into your office, into the clinic with this pattern, but have no symptoms. You can usually give these patients reassurance because they are unlikely to have reentry, like atrioventricular reciprocating tachycardia, if by their late teens they've had absolutely no symptoms. However, some patients do develop palpitations and do develop an underlying supraventricular tachycardia. And so this is an example of AV reciprocating tachycardia. And we call it orthodromic reciprocating because it's coming down the AV node and then up the accessory pathway. And because it's going in the normal direction, then we have a narrow QRS. Now we know that this is not antidromic AVRT because antidromic AVRT is usually only with a wide QRS, since the electrical signal enters the ventricle through the accessory pathway, and that involves slow conduction of through the muscle in the ventricle, and that's a really wide, ugly QRS pattern.